All right, I want to welcome everybody for the continuing SSAT series, Mentors of the Month. And I'd like to welcome Dr. Vic Velanovich, who I'm lucky enough to have as my mentor. I know a lot of people in SSAT know him very well. He's the former program chair. And my name's Adham Saad, and I work here. We both work here at University of South Florida. And so we're just going to do some casual questions about mentorship and his career and what advice he can give to all the people out there. So if you're ready, we'll just start.
Well, thank you. Thank you for having me.
Great. So I know that a lot of people come to you for advice on looking for their first academic job. Can you just talk about sort of generalizations on what advice you have for people looking for that first academic job?
Well, my general advice for everybody, whether in job or any other decision in life, is the most important thing is to know yourself. Know what's important for you, know what's not important for you, and really and have a good handle as to what is really important, what is going to make you happy, what is going to make you fulfilled. Because with every decision, what you're really doing when you're choosing to do one thing, what you're really doing is choosing not to do something else. And is that joy of what you chose to do worth the regret of what you chose not to do? So that is the most important thing. And for some people, it's going to be different things. It's going to be the type of job. It's going to be where the location is. It's going to, maybe for some people, it's going to be salary, promotion. So it's really, again, just very important to know what you think is important before you go on that job hunt, and not get too caught up in what other people tell you what you think should be important for you.
Okay. And, you know, I've heard you give this sort of advice to a lot of residents, and I know you've always told them, pick 2 out of 3, right?
Well, again, it's you're unlikely to find a job doing exactly what you want to do, exactly where you want to be for exactly the amount of money that you're going to that you may want. So you got to figure out which one of those or more are going to be what you really want.
Okay. And then when residents come to you and they tell you, hey, Dr. Velanovich, I'm looking at academic jobs. I've also got these other private practice jobs. What is your sort of take on private practice and academics, and sort of which direction, how for them to choose their direction?
Well, it depends on really what they want to do. If they just want to be in the practice of surgery and they want to do operations, take care of people, then private practice is kind of where they should go. If they're interested in research and teaching, then you're going to be more toward academics. However, I will say something that you can do academics anywhere. Some of the most academic people I know are in private practice. As I like to say, academics is not the building your body is in, but the state your mind is in. And anywhere that you have curiosity and are looking at your practice critically, you're doing academic work. And quite honestly, a lot of us in academics are doing the equivalent of private practice work when we're just taking care of patients. So it's not as a clear-cut difference as some people may like to think.
Okay. What if somebody ends up taking a job and it's their first job out and they find themselves unhappy?
The actual statistics on that, and I haven't looked at this recently, but over 80% of people leave the first job that they take. And people, when I tell people this, they seem shocked and may seem scary, but on the other hand, it's actually quite comforting. You don't have to make the right choice that first time. Most people will end up moving for a variety of reasons. It may be that, again, the practice wasn't the type of practice they expected to be. Family circumstances may have changed. They would rather be someplace else. So it is all right to have a starter job, so to speak, with the idea that you're going to be moving on elsewhere. Because very few people stay in their first job that they ever had.
Okay. And when these people are first starting out in practice, and you've seen a lot of people come and go, both here and at Henry Ford, Well, what do you think is the biggest mistake people make when they're first starting out?
They're asking the wrong questions. You know, when people usually come and interview for work, they want to know, well, what am I going to be doing? Where's my office? How much I'm going to get paid? That type of thing. What they really should be asking is, where are the patients coming from? How are you going to help me recruit those patients? How are you going to make my introductions to the referring physicians? What is the partnership structure? Who are going to be my mentors? What happens if I get in trouble and need help? Who's going to come help me? Those are questions you really should be asking, because that's what's going to affect your day-to-day life. In addition, particularly if you have a family, you may need to ask family-related questions. What are the school situation like? What is the child care situation? Is there a potential job for my spouse? So these are the type of questions you should be asking, and you end up with being more likely to end up in a situation you want to be in.
Okay. No, that's really sage advice. So what if we change gears a little bit and get a little philosophical? So, you know, you've had a long storied career that's ongoing. If you had to look back on your career and you had to change your trajectory at one point or another, what would that be and why?
Yeah, that's a real tough one, because you know, I've been very fortunate in my career. I've stumbled across good opportunities. If I were to change one thing, I think I would have liked to have had more formal training in research. What I'm talking about is the funding part of things, how to get projects funded, how to get those type of things off the ground. Didn't really have any of that in my training in the Army, where it wasn't the focus of that. So probably that'd be one thing that I would change.
Well, for somebody without formal training, you're very well published. How did you sort of engineer that without actual formal training in it?
Well, I was always interested in research, even in college. I figured out what I needed to do in order to get projects done. What would be the requirements for to get to solid conclusions based on the data that I had, and I always did things that I was just interested in. I try not to force anything where I know it couldn't get done. I was just like, what do I have available here? What am I working on? What's interesting to me right now with what I have, and that's where most of the papers ended up coming from.
Right. Okay. And so I think one of the things I admire most about you is when I first got here and had some time to just kind of watch you operate with the residents, is your ability to teach in the OR. And I think that's a very underrated and undervalued skill in a lot of places. What's your philosophy when you're going in to a case with a resident, and how does that change with the level of resident you're working with, and how have you done that over the years?
I have to say, the way I teach residents very much reflects the way I was taught when I was a resident.
Mm-hmm.
Particularly, I had a couple of excellent surgical mentors, very well-trained surgeons, very experienced. Dr. Preston Carter, retired colonel in the Army, and Dr. Joseph Homan, who's now another retired colonel in the Army. They were both excellent surgeons. And the way I teach was the way they taught me, quite honestly, which is we kind of go along the case, we let you do things as much as you can do until you demonstrate to me that you can't do it, and then try to show you how to do that. It does require a certain amount of patience, and certainly is not for the faint of heart, but it's very rewarding.
Yeah, and how do you get a resident? Because oftentimes, especially with laparoscopic stuff, residents get frustrated, and the more frustrated they get, the worse their skills get, and they sort of lose focus. How do you get them through that part?
Well, that's an excellent question. The way you have as a attending surgeon when you're working with a resident, first of all, you have to know kind of how the resident responds to certain type of instruction, and making sure you're clear in the instructions. And then you have to recognize what is it that they are not seeing that you're seeing, or what are they doing that they should be doing. It may require adjusting their hands. It maybe require something as basic as adjusting their footwork and their positioning, or pointing out the salient anatomical features that need to be addressed. So then getting a good, then being very kind of clear of the kind of expectations as we go along. Of course, things change as a case goes on, and you have to be able to adjust.
Absolutely. So, to stay on the resident topic, you've seen the transition and many years afterwards as far as resident duty hours. You trained at a time when you didn't have any hours. You were just kind of there. What do you think about the duty hours? What do you think those have done to benefit the residents and benefit their education? What do you think it's done to people getting out and going into practice immediately? The good and the bad.
Well, the good is that you don't see people that are just completely worn out. I do think that is a good part of the duty hours. It also allows people more time to read. Also allows people to have more time with family and friends. They don't quite miss as many important events as we missed. On the other hand, the bad is that you have more handoffs, and when you have more handoffs, you have more opportunities to fumble. And so trying to minimize those fumbles is really an important part of the duty hour restrictions. I remember when the restrictions came about, and there was a lot of concern, particularly among the curmudgeonly class, that somehow residents would lose the sense of ownership of the patient, or they would develop a shift work mentality. I have to tell you, I have not seen that. And I think it's just I think medical students going into general surgery is kind of self-select. In a sense that I will frequently say, give me anybody of average intelligence and an overdeveloped sense of responsibility, and I can turn that person into a surgeon. And I think we still see that.
Yeah. Do you think that residents graduating today versus before duty hours, do you think their technical skills or their abilities to sort of operate independently have suffered?
I think their self-confidence has suffered.
Okay.
And you see that they're voting with their feet. Almost everybody does a fellowship these days. Certainly when I graduated general surgery, only people that went to fellowships were those fellowships that you had to go in order to be able to do that type of work, like cardiac surgery or plastic surgery or transplant surgery, something like that. But right now, I think that residents feel like they need to have the extra training in order to feel more confident that they have the skill set that they need. Now, confidence is a funny thing. You know, some people have excellent skills but lack the confidence in their skills, and other people not so much skills but a little bit too much confidence. So it's important to kind of get that right.
Yeah, yeah. And do you, so sort of transitioning from that question, do you think true general surgeons are a dying breed? Do you think we're just not seeing it because we're at a big referral center and a lot of our residents are going into fellowships? One, do you think it's a dying breed? And two, do you think that's a good thing or a bad thing?
I don't think that they are a dying breed. I think they're just well hidden. Certainly if you go into a rural or small community practice, you will have general surgeons there that are doing a wide variety, including vascular, thoracic, endoscopy. So there certainly is practices out there and communities out there that if they didn't have the broad-based general surgeon would have either have to travel great distances or would have not the care that community needs. The second part of your question has to do is having fellowships a good thing. Well, I think it is, if for nothing else, that it provides another layer of training so that people have more confidence in their own skills.
Yeah. And so to sort of move forward with that question, do you think people like hyper specializing is a good or bad thing for patients and patient care?
Yes and no. If it is a hyper specialized type of procedure that is relatively independent of the other organ systems, it's probably okay. On the other hand, somebody still has to take ownership of the entire patient care experience, and that requires still a broad-based knowledge foundation.
So when you first got out of residency, how many years do you think it really took you to really sort of exhale and be comfortable in the OR? And I know you're going to say I'm still not comfortable in the OR, but really, you know, where you just are like, okay, I'm comfortable, I'm in command of the room, I am able to do this and not feel like, you know.
Yeah, probably. I was fortunate. I mean, I did my training in the Army. We had a lot of independence as a resident, way more so than what is allowed now, quite frankly. And when I went to my first duty station, I had 4 great partners, and we used to do every big case we used to do together. So the guy across from me helping me out was another board certified or board eligible general surgeon. So I feel that it happened relatively quickly, maybe, I don't know, a year or two.
Okay.
And like I said, we did everything, but again, we had a lot more independence in training.
Right. Okay. Do you think, so going back then, do you think the fact that you had so much independence as a resident as opposed to residents now, do you think that it's going to take these residents graduating, this generation of residents graduating, longer to sort of get into that comfort zone?
Well, that's why they have these transition to practice fellowships, is because of
Right.
that. So, it depends on the individual. It really just depends on the individual. I hate to make broad, sweeping conclusions about everybody.
Yeah, sure.
But some people, it comes more naturally to than others.
Right. So, as I've worked with you over the last several years, what the thing that one of many things that I admire about you is that you really do a good job of doing the whole work-life balance thing. You spend time with your family, you spend vacations with your wife, et cetera, et cetera. What's your best advice for people to really be able to keep that balance going?
Well, I'll go back to my first statement of really know what's important to you, and then prioritize the important stuff and say no to the stuff that's not important.
Yeah. Yeah.
That's it's as, I don't want to say it's as simple as that, because it's not that simple. Essentially you have to everybody in any situation has a certain amount of responsibilities. You have to prioritize your responsibilities, and so, what am I really responsible to make happen? Those are things you should prioritize, and then the stuff that is you really shouldn't be responsible for, or not responsible for, that goes way down on the priority list. You need to fulfill your responsibilities as a physician, as a parent, as a spouse, and once you do that, if you have any time over, then you can goof off.
So, what? I know your wife very well, and I'm quite fond of her. What advice do you think she would give to spouses? Because she's been by your side and supportive of you for a very long time.
She would say, be your own independent person, and you know what? There's a lot that comes with the territory of being a physician spouse, and the best way to handle that is to be your own independent person. Be able to make decisions on your own. Be able to find your own joys in life, and just not live in your spouse's shadow.
Okay.
And you know she does that.
I do. I know she's the boss. So, we're kind of running out of time here, but just a couple more questions. So, I think if I think about the hardest thing about the job that we do, it's, one, worrying about patients all the time. And then two, when there's an unfortunate complication, it's that very first case back after a major complication where you're still upset about it and you got to sort of, go forward with the next case. What's been your philosophy on handling that? What have been the struggles? What have been, how do you get through that? Because I really think that's probably, for me, the hardest part of the job.
Well, it's still hard. Every complication is hard. None of them are easy. All of them make you question what you did and whether you should be doing this. Your specific question about what you do the first case back, all you can do is just focus on what you're doing right at that moment. And as hard as it is not to think about what just happened, you need to refocus on the individual that you're caring for right now, and that individual deserves your undivided attention.
Okay.
And he or she doesn't deserve you languishing in your own sorrow.
So, with all that being said, and in our day and age, if you were going back and had to do it all over again, would you do it all over again? Would you be a surgeon again? Things have changed a lot.
Things have changed a lot.
And I hear about your frustrations.
They have changed a lot. If again, everything being the same, I would say the answer is yes. Surgery's been a very fulfilling career. I've had a lot of fun with it. I've met a lot of wonderful people, both as patients and as colleagues. So that part is just a wonderful part. I got to do a lot of interesting things that very few people get to do, and so it has been very good to me.
Good. Well, great. Well, one more question. Why do you think the robot's the devil?
Well, as I say, because you've heard me say this before, when the robot needs an operation, the human does it. When the robot starts operating on other robots, then I'll buy into it.
All right. Well, with that, we appreciate you guys listening to us. As you can see, Dr. Velanovich is a wonderful mentor to everybody that he comes across, and I'm lucky to be able to work with him every day and get his advice on a daily basis. So thank you very much, Dr. Velanovich, for having us.
Thank you for having me. This is great.
Thank you.